Okay, very good afternoon to one and all present here. At the outset, I'd like to thank Dr. GVK for the opportunity and also to be sharing the stage with Dr. Jaisri and Dr. Shanmugovelu. It's always a pleasure. And it's been a lot of interesting things that we had to discuss when we put up these slides. And as I was just coming to this talk, I just Googled up what exactly Jugalbandi means, right? So we are very used to Jugalbandis in the world of Carnatic music and Hindustani music. So I was like, what does Jugalbandi mean when it comes to a medical conference? But then Jugalbandi literally means a set of entwined twins. So for the next half an hour, I'm going to be Dr. Jaisri's twin and she's going to be mine. And we're going to give you a talk together on pregnancy, diabetes, and metabolic health of the mother and child. So this is a very, what should I say, I'm very fond of this slide whenever I put up a talk on gestational diabetes or hyperglycemia and pregnancy, because this was stated by Matthews Duncan way back in 1882. So he said diabetes may come on during pregnancy, it may occur only during pregnancy, being absent at other times. It may cease with the termination of pregnancy, recurring sometime afterward, and pregnancy is liable to be interrupted by the death of the fetus, and that dead fetus is sometimes described as enormous. I think this really gives us the definition that we want of gestational diabetes, and if you actually look at it, not much has changed, right? Considering the heterogeneity of diabetes and the heterogeneity of hyperglycemia and pregnancy, this exactly describes what we have been trying to unravel for the past 3-4 decades when it comes to understanding GDM and hyperglycemia and pregnancy. So I will now start off with Dr. Jaisri's contribution. What are the normal metabolic changes in pregnancy and what happens in a diabetic pregnancy?
So I think, first of all, good afternoon, and it's a pleasure to be back again. I think what we need to keep in mind is that insulin resistance is a normal feature of the pregnancy. All women become insulin resistant mainly because the fuel has to be shifted to the baby. So particularly they develop a lot more resistance to the action of insulin on the adipose tissue, so that all of the necessary nutrients go to the baby. But only some of them go on to develop gestational diabetes, and depending upon the population, of course in our country, in urban areas, I think we are estimating the prevalence of gestational diabetes is somewhere around 13 to 15%. Yes. And if you keep in mind that this is a group of people like we're going to be talking about, it's sort of actually a marker for future development of NCDs. Because the people who actually then go on to develop gestational diabetes on this background of insulin resistance means that the body is not able to make enough insulin to overcome that insulin resistance, exactly what we find in diabetes. So go ahead and talk about the...
Yeah, absolutely. See, taking it from there, ultimately all that we need is a balance between the insulin resistance of pregnancy, which we all know technically peaks around the end of second trimester and beginning of third trimester, and over and above that, all you expect is a satisfactory compensation as far as the beta cell response is concerned. So when that balance is not met, you naturally end up seeing some degree of hyperglycemia, and this is what we term gestational diabetes as we see in clinical practice today. So why are we so concerned about this entity? I think all of us are very familiar with the Pedersen's hypothesis. Now, hyperglycemia in any form is considered to be teratogenic because hyperglycemia can well cross the placenta, go over to the fetal side, stimulate the fetal beta cells, and from there on result in macrosomia and developmental problems in the baby. And it is not only hyperglycemia that we are worried about, it is a lot of mixed nutrients that we talk about. So it's not just the sugar, you're also concerned about the lipids, you're concerned about the amino acids. So when all of them diffuse on and reach the fetal circulation, you have a lot of things going on with fuel-mediated teratogenicity, and that is what we try to modify, prevent, and treat as far as this condition is concerned. And depending on at which trimester you have this kind of effect on the pregnancy, you may find changes which are proportionately different in each trimester of pregnancy. So if one comes in with a lot of hyperglycemia in the first trimester, you may find a lot of issues with organogenesis. The mid one may be more of behavioral changes, and towards the later half of pregnancy, normally we find a lot of anthropometric changes with respect to a big baby or macrosomia, dystocia, so on and so forth. So ultimately the point is that hyperglycemia, even prior to conception, all through your pregnancy and even post delivery, is a major factor that we need to be very attentive and sensitive to. And we'll just discuss this in a form of a case. Now, this is a 27-year-old primate, 26 weeks pregnant, no family history of diabetes, pre-pregnancy BMI at 23. She undergoes a 75-gram GTT, and the fasting is 100. The 2-hour value is elevated at 153. So naturally, we are all faced with such a case quite often in clinical practice today. So does she have GDM, and what are we going to do about this?
So the definition of GDM has sort of changed over the years, I would say. I still like to think of it as a glucose intolerance of any degree detected for the first time during pregnancy, because the case that I presented is the so-called classical GDM that comes on with a peak of the insulin resistance at around the 7th month of pregnancy. However, now, because we are doing GTTs even early on in pregnancy, we are going to pick up a subset of women who may have had pre-existing glucose intolerance, which is worsened in the pregnancy, even in the first trimester. So I'd like to think of it like this. I don't break my head about whether it's pre-existing diabetes or whether it is actually diabetes. Apart from, of course, if you do a HbA1c and is high, because I'm worried about organogenesis in that situation. But otherwise, glucose intolerance of any degree, I would classify it as diabetes in pregnancy, gestational diabetes, if it happens later on. And this is irrespective of whether insulin is used or not for treatment, and irrespective of whether the condition resolves after delivery. So it might have been pre-existing diabetes, which we picked up for the first time in pregnancy, and sometimes it remains after delivery, and sometimes it resolves after delivery, but gestational diabetes is this. So it obviously does include undetected previous type 2, rarely type 1 and LADA is also picked up in pregnancy. We all come across women who present with a HbA1c suddenly of 12 for the first time in pregnancy, and we know it is not the classical GDM. So in my mind, I think of the classical GDM as the one that comes on only at 24 to 28 weeks and which resolves after delivery. For me, as we will be talking, for me this is more a marker of the future risk of this mother for diabetes and other NCDs, as we will be discussing.
1 minute, madam. See, in this particular case, fasting 100 and 2 hour following OGTT 153. Do you like to estimate A1C in this case?
Not in this one. She's at 27 weeks.
27
I would not do a HbA1c in this case. Only in early pregnancy when they come in, I would.
Worried about the pre-existing diabetes.
Thank you, sir. Thank you for that.
Yeah, so she is told that she has gestational diabetes, and what are the concerns?
So when we talk about the problems with gestational diabetes, these are our concerns. We'll go over some of them in detail, but we need to think of both the short-term in the pregnancy problems. So things like this lady is more likely to develop hypertension in pregnancy. She may have this problem if she has a macrosomic baby. She may have failure to progress in labor, higher chance of cesarean or instrumental delivery, preterm delivery, and preeclampsia. The fetal complications, which I shall be talking about, but mainly what we are worried about is the macrosomia and the shoulder dystocia. But it's not only this, Lakshmi, that we are worried about, is that right? I mean, not just the problems in the pregnancy.
Right. Yeah, like ma'am said, you are looking at pregnancy concerns in the mother in pregnancy diabetes with respect to the adverse pregnancy outcomes that can happen immediately. We are also interested in looking at the fetal outcomes, which are the short-term outcomes with respect to the prematurity, macrosomia, the incidence of NICU admissions, hyperbilirubinemia, congenital anomalies. Now, these are all things that just pass with the initial phase of neonatal life or puerperium or whatever. So these are things that we are really, really tuned to. So when you look at somebody with altered glucoses in pregnancy, you are well tuned to looking at the immediate complications, which is what you want to prevent in both the mother and the child. But what we are also trying to foresee here is the long term as far as both the mother and the child is concerned. So with respect to the mother,
yeah, so the long-term complications. So when I see this lady presenting at 27 weeks with gestational diabetes, I'm also concerned about her future risk for all of these things which are listed here. Can you just go to the next slide, Lakshmi? Yeah. So this is a slide which basically shows that what is the prevalence of gestational diabetes and how does it foresee or how does it portend the risk of progression to type 2 diabetes, so global perspective. So you can see that we are in the group where there is almost 11 times higher risk of developing type 2 diabetes once you've been diagnosed with gestational diabetes. So I think this is something that we need to keep in mind when we are treating this pregnant woman with diabetes, and also pass on that information to the treating gynecologists, that they also need to be careful about follow-up in this group. Some of the other concerns with development of diabetes in pregnancy in the mother. Studies have shown that women with prior GDM are at higher risk of cardiovascular disease. So 1.74 is one of the estimates that I found in the paper. And this risk increases even by 5 years, particularly now that we are seeing older women becoming pregnant with other multiple comorbid risk factors, like obesity and dyslipidemia and hypertension. This increased risk of cardiovascular disease seems to occur as early as 5 years. I think we are all understand the fact that pregnancy is a situation that causes some vascular changes. I wouldn't call it a vasculopathy, but definitely it is something that is causing vascular changes. And that propensity initiated during pregnancy sometimes manifests very early on, even within 5 years, and it persists even up to 25 years. So even when we see a 20-year-old woman, in fact, the AHA now includes a history of GDM in their classification of the so-called cardiovascular risk enhancers in women. So a history of GDM is a risk enhancer. We've been talking about the cardiometabolic kidney syndrome, the CKM syndrome, what you're talking about, and that history of GDM is one of the risk enhancers. There is some data to say that women with a history of GDM have higher rates of microalbuminuria and renal morbidity, and some sort of a controversial link with cancer. If I think of GDM as the root cause being insulin resistance and inflammation, I am not surprised by this study. There was one study which showed that women with GDM had a higher risk of various types of cancers. I think this will completely only track with the BMI and the obesity, which itself increases the risk for gestational diabetes.
Madam, in this case of cancer incidence with the previous history of gestational diabetes, did they do any genetic studies linking? No.
No. This is all like just population-based surveys.
Right, and moving on, with respect to the offspring, now obesity is something that we are concerned about because you know that one can produce a large for date gestational age baby when it comes to the offspring of a GDM mother. So there were studies which showed that the offspring of GDM mothers, they had higher BMI in childhood. However, after adjustment for maternal pre-pregnancy BMI was done, this association actually disappeared. But they still found a positive association between the maternal glucose levels and the adiposity as far as the child was concerned. So ultimately the point is that these children tend to have a higher BMI as they grow, and they're also at higher risk for impaired glucose tolerance 10 to 14 years postpartum. And the next most important point that we need to keep in mind is the neurocognitive development of the baby. I think in today's day and age, we need to really pay heed to the fact that maternal GDM, particularly untreated, can lead to higher prevalence of ADHD, attention deficit hyperactive disorders, and autistic spectrum disorders in children that are born to diabetic pregnancy mothers. Now, this is again one of the things which looked at the BMI of children that were born out of diabetes, type 1 DM, type 2 diabetes, GDM which was treated with medications, GDM that was not treated, and normoglycemic women. So it was pretty much same till about 3 years of age, but after the age of 3, as far as the child is concerned, you can see that the lines actually start to separate. So you have the highest BMI for children that have been exposed to diabetes in the form of type 1 or type 2 diabetes in the mother, followed by GDMs that was treated, followed by GDM not treated, and euglycemic women. So ultimately the point is that there is a hierarchical increase in the BMI no matter what kind of diabetes the child was exposed to in utero. And again, this is another compilation of what happens as far as autistic spectrum disorders are concerned in the children that are born to women who had hyperglycemia and pregnancy. And here again, they had an interesting observation where they found type 1 diabetes had the highest association with autistic spectrum disorders, followed by type 2. And when they actually looked at GDM, they found that earlier the women were diagnosed with GDM, the more was the incidence of autistic spectrum disorders. So in other words, the duration of exposure to hyperglycemia in utero really decided autistic spectrum disorders in these children, because people who had GDM diagnosed in the later half of pregnancy and non-diabetic women had probably a lot less rates of autistic spectrum disorders in the children. And similarly, when they looked at ADHD and asthma, the curves were pretty much similar. Incidence of ADHD was much higher in type 1, type 2, followed by treated GDM, followed by euglycemic women. And in fact, GDM that was not treated behaved pretty much like euglycemic women. So here again, there was a positive association between diabetes in any form during pregnancy and fetal outcomes as far as neurocognitive disorders were concerned. And asthma in the children, again, this also they found that pre-existing type 2 diabetes and GDM did have an association with the incidence of childhood asthma in the offsprings of these women. So to summarize, when we find a woman with GDM, we are not just looking at the immediate concerns. We are not just stopping short with short-term complications or short-term outcomes. We are looking at hand-holding her till probably the rest of her life as far as both the woman and the child is concerned. So that is the point that we are trying to drive across here, because when you look at the long-term complications in the child, when a child is born of a GDM pregnancy, there is a lot of fetal insulin macrosomia that happens, and when this child already has the epigenetic signature that is there with a diabetic pregnancy, this, when it comes in with the environmental alterations that happen as the child grows, naturally will really propel a lot of childhood obesity, diabetes, and cardiovascular disease. And needless to say, if this is a girl child, she will go on to become obese, she will go on to have GDM, and she will again produce one more child which has the same metabolic memory. So that is the chain that you want to cut when you look at somebody with gestational diabetes.
Lakshmi, and one question. Now I have a patient, early GDM. What is the risk for ADHD? Number one. Patient with established type 1 and type 2, presenting with poor control and early pregnancy. What is their risk of ADHD in that case?
Exactly. People who had type 1 diabetes and established type 2 diabetes with poor glycemic control, the incidence of ASD and ADHD was much higher compared to GDM population. That was the message that was given there. So then moving on, the risk of NCD. So this is one slide that I really liked, because when you look at GDM in one pregnancy and GDM in subsequent pregnancies, all that has to ring in our ears and our senses is that you're not just looking at the child, the mother in front of you, you're looking at the risk of NCDs in both the mother and the child for the future generations. Screening and diagnosis.
So, I mean, I think it's important. I mean, ultimately, I think all of us agree that prevention is important, though we keep saying that, so getting a pre-existing diabetic to become pregnant at a time when she's euglycemic is very, very important, and preventing GDM in the mother by reinstituting healthy practices pre-pregnancy and in early pregnancy is also important. Of course, the target blood sugars are this: a fasting below 95, 1 hour below 140, and a 2 hour below 120. So this lady would be counseled on, next slide, yeah, I mean, she'd always be advised on diet and exercise. Go ahead. And so diet and nutrition, the ICMR has come out with some pretty clear guidelines. They say that don't go below 175 grams of carbohydrate. They recommend that that is a must. Try not to go below that, with a minimum of 70 grams of protein and 28 grams of fiber. That's the current ICMR guidelines. And this is how they expect to distribute it. This I think we're familiar with. Go ahead, Lakshmi. And this is for an average weight gain of 10 to 12 kilos all through pregnancy, and they need around 300 to 350 calories extra per day above their normal adult requirement, and that is enough. We need to be careful about restricting the calories too much, because that causes ketonuria, ketonemia, which has an impact upon the IQ of the baby later on in life. And obese pregnant women, however, caloric restriction up to 30% can be suggested, and it is believed to be safe. And 70 to 80% of women do achieve normoglycemia with just lifestyle modification. Go ahead. Yeah. So this lady returns, in 2 weeks she's been counseled on diet and exercise, but she still remains above our target. Fasting is 97, 2 hours is 155, done in the lab. She's also checked her blood sugar with a glucometer, and a post-lunch and post-dinner is okay. So how do we manage her now, Lakshmi?
Yeah, I think this is time to start out with insulin, right? Obviously, because we really don't wait too long when it comes to gestational diabetes, because you are looking at a short-term control to give you a better outcome as far as the pregnancy is concerned. So insulin naturally becomes your go-to choice when it comes to initiating, anti-diabetic therapy when it comes to GDM. So glycemic level of the mother becomes the most important parameter. That said, it is always a good practice to look at the fetal ultrasound and look at the anthropometry of the baby. So it's very important to look at the abdominal circumference, very important to look at the Likert, and also important to look at the growth profile, because quite often you will be surprised to see that even though the maternal sugars are technically within the normal range, you will still see an antenatal report which shows polyhydramnios or a large baby. So that itself becomes an indication by itself to start insulin, because it only tells you that for this index pregnancy, the child perceives the maternal sugars to be high, and again here you will have to initiate insulin even if you find a seemingly normal sugar as far as the mother is concerned. So ultimately, look at both the baby and the mother and then make your choice, and insulin definitely is the go-to drug. So human insulins, I will not spend too much time on this, because how we choose and what
Lakshmi,
we give.
I just want to interrupt. We are coming across many babies, as you said, in spite of the mother's blood sugar being normal, the babies have all the problems. This is because of the fetal handling. Why not that? Fetal handling of the maternal glucose. Usually after 10 weeks, the fetal pancreas starts functioning, and first it tries to help the mother to reduce the blood sugar. So the mother's blood sugar is normal, but the excess blood sugar on the fetal side gives all the problems, as doctor said, due to hyperinsulinism. The fetal renal threshold is 110. Once it crosses, it can cause polyuria and hydramnias. All this we'll have, but the mother's blood sugar, it will be normal.
Exactly. It is the diabetic phenomenon that the fetus experiences as it goes in, right? So choices of insulin, again, it is largely up to what you want to use, because generally human insulins have been time tested as far as safety and efficacy is concerned. You also have analogs today, aspart, lispro, and detimur. So ultimately you start out at 0.3 to 0.7, but largely you can use a basal bolus. Premixed can also be chosen, because mostly you have an issue with the postprandial hyperglycemia when it comes to pregnancy. So you can choose the regimen that you want as far as you achieve the glycemic control. So I'll not spend more time here. I will go on to metformin.
So there's always this controversy
Another
about
thing
metformin.
I want to ask from you, usually we say we divide the basal and bolus as 50%, 50%, but here it is not working. We need more of short-acting, postprandial
control.
So the metformin can be used. The NICE guidelines say that we can initiate it right from the start of pregnancy. The ADA says and the ACOG says that we can use it after 28 weeks if they're already not taking it. I just put this up because they said that the maximum dosage of metformin that they recommend is 500 mg twice daily. And if at all we're going to prescribe metformin, and if they've never had a creatinine check, please do check a creatinine. I mean, I think it's just basic common sense. The controversy about metformin is that it definitely causes a little bit of a reduction in the birth weight, and these babies are born slightly earlier, about 5 days or 1 week earlier compared to babies who are not on metformin. However, after birth, when these children are followed up, in the mixed study, when these children were followed up at 5 years, there was no difference in BMI. The same number of kids were obese, what Lakshmi was talking about earlier. There was no difference in BMI. So while the effect of the metformin was there as long as we were giving it in pregnancy, after delivery there was this catch-up growth, and there was no difference by the time they came to 5 years as compared to the group that was put on insulin or diet. Of course, fetal surveillance is very important. These are the usual things. In the first 3 months, we screen for the 3rd month scan, and the 5th month scan, we are screening for congenital anomalies. At 22 weeks or 24 weeks, we do a fetal echo, detailed fetal anatomy. And then after 28 weeks, depending, some doctors do it every month, some doctors do it every 2 to 3 months, just assessing the fetal size. And of course, the other well-being of the fetus, the biophysical profile testing, particularly umbilical Doppler. But these are the minimum that needs to be done. As far as the mother is concerned, corticosteroids need not be withheld if she has diabetes, provided the sugars are under control. But in addition to monitoring the sugars, for all GDM mothers, particularly if they are using steroids, please monitor the blood pressure and the urinary protein, because they will be at high risk for developing hypertension in pregnancy. This lady then is started on insulin, as Lakshmi discussed, for the control of the PPBS. And however, this is another common problem that we come across. Because we've emphasized the importance of keeping the sugars under control, she is on a very strict diet and she doesn't gain any weight. Next slide. This is the ideal recommendation for weight gain. Like I said earlier, mostly, if we remember, 10 to 12 kgs. However, if they are overweight or obese, maybe around 5 to 8 kgs. If they are morbidly obese with a BMI of about 35, less than 4 kgs is what is recommended. This is what we recommend. What they achieve is different. Normally, some of them go the other extreme. They eat much less than what we recommend because of the fear and increase in the blood sugars. We can make sure they are getting adequate calories by checking their urine ketones to make sure that they are having adequate carbohydrate intake, and we can increase protein intake to achieve good blood sugar control and achieve the caloric intake without increasing the blood sugars. She continues on insulin, diet, exercise. She grows normally. We do all the appropriate monitoring, and we take care of the normal things that happen in pregnancy, like frequent low blood sugar at night. And she delivers a baby at 38 weeks, normal delivery, 3.2 kgs. So does our job stop here, Lakshmi? Are we happy? Can we pat ourselves and send her away?
In fact, I would say our job starts here. Right? It is not a fairy tale ending, so it is not just that you stop with delivery. I think that is one take-home message after all this. So you will really, really have to emphasize to this woman that coming back to us after delivery is what is the most important factor when it comes to gestational diabetes, because if you actually look at the data, obesity and abnormal weight gain during pregnancy and failure to lose weight after delivery, they are very strong predictors for recurrent GDM and cardiovascular disease. So that is what you want to prevent. That is what you're also interested in, apart from producing a good fetal outcome as far as the pregnancy is concerned. So you are really looking at the long term, and taking care of weight gain and obesity is probably the lowest hanging fruit. I think that is the simplest thing that you can ask this woman to do. Forget everything else. Take care of weight and half your problems are solved. So the first 1 year after delivery is what really, really defines the metabolic profile of a woman. So dysglycemia and weight gain at this point of time is extremely, problematic to the mother. So which is why we even talk about this as a 4th trimester concept, like how in examination of abdomen, we don't stop with 9 quadrants. You say the genitalia, you say the left supraclavicular, you have extra 10 and 11th quadrant. Similarly, when you look at pregnancy, don't just stop with 3 trimesters. Look at what happens to the mother in the next 1 year after she delivers the baby, because that 1 year is going to pitch her for the rest of her life. So prenatal, early postnatal life, they really offer a window of epigenetic plasticity. So what you do then really, really sets the tone for the rest of her life.
Lakshmi,
So
I just want to interrupt now. Sorry, you have come. Lactation is very important, because whatever metabolic aberrations.
Exactly. Very true, absolutely. So I think in today's day and age, you really have to emphasize about lactation, because we have a lot of these women who are working, and they also have a delivery which is slightly later in age than what happened, say, a couple of decades ago. So everybody is in a rush to resume work, everybody has their own priorities, but ultimately, I think we really need to emphasize the importance of lactation, like ma'am said, because when you actually look at the data from lactation duration and development of type 2 diabetes and metabolic syndrome in postpartum women with recent gestational diabetes, they found that in women who had exclusive breastfeeding up to 6 months and carried it on with complementary feeding up to 1.5 to 2 years, the incidence of both prediabetes and metabolic syndrome was definitely lesser. So I think these are points that we really have to talk to them, right? This has to start the moment they enter sometime the 2nd trimester, the 3rd trimester, you start talking to them, start, giving them the mental framework of what is expected out of them after delivery, right? Because everybody is happy once the baby is born. The entire household is in a celebration mode, right? And the mother is forgotten. I think that is not what we want, right?
Whatever metabolic aberrations that would have occurred because of GDM, that gets reversed during lactation.
The hormonal changes actually get reversed, and insulin resistance also improves when lactation is better. So that is how mostly they all reverse when lactation is good. So early intervention in high-risk women has been shown to improve outcomes in future pregnancy and prevent long-term diseases. So we all understand that pregnancy and gestational diabetes is a major factor when it comes to intergenerational and transgenerational risk transmission from mother to baby. So like we say, the first 9 months of life is what is going to decide the rest of your life. So it is not just that we resemble our parents in the way we look. What we are inside is also largely determined by what our parents gave us and what we are going to give the next generation. So that is the point that needs to be driven across, and risk need not be destiny. I think I will just leave you with the thought, because we have really admired pathology for a very long point of time. We have understood GDM, we know how to treat it, but what are we doing to prevent recurrent GDM and type 2 diabetes and cardiovascular disease in the mother? I think that is the major task ahead of us, and all of us in this room are probably responsible to take care of this aspect. We will stop here, and thank you very, very much.
Actually, before the discovery of insulin, pregnancy is contraindicated. Actually, then after the discovery of GDM, when we say pre-GDM, it was only type 1. But now, because of the epigenetic transmission, what we are getting is early GDM.
Yes.
That is, it's occurring in all 3 trimesters. And as you said, if it occurs early, the intensity of problems are very much high.
Actually, Dr. Lakshmi, we come across a lot of patients. These patients are being referred by gynecologists. We provide them positive motivation, proper education during each and every visit.
Absolutely.
Right.
Right.
After delivery, they never come back.
That is very,
But
exactly.
again, with second time
They come
GDM
back.
or established diabetes with pregnancy,
Yeah.
they come to us.
They remember us only when they want us.
அவங்கள்ட்ட கேட்டால் ஏங்க நீங்கள் வரலன்னா எங்களை வீட்டில் அனுப்பல சார் அதனால தான் நாங்கள் வரல எனக்கு டைம் ஆச்சு அதனால தான் வரல.
Which is why sometimes we may have to link up with the pediatricians, because there they will definitely go for vaccination. So
one thing, what they have done a recent study in US and found that at the time of delivery, discharge, that is just 3 days, all the hormonal changes of placenta is relieved, so they come back, revert back. So when they compared the GCT, what they did at time of discharge was equal to what we do at the 30 to 45 days. And this has been again done in our maternal hospital, MH, by Dr. Geeta Lakshmi, and she has also shown that it is the same. So when you discharge her, you do one and find out if she continues or not, because the placental influence has gone. Do that time, at that time, because it's very difficult to bring them back after a month or 45 days.
Right.
Thank you very much, both the speakers. You have participated in a very elegant and an excellent informative way. Thank you, madam. Thank you so much. Thank you, Dr. Lakshmi, for nice presentation. Impressive one. Right.